Gavin Perkins. Thank you very much for coming here to deliver this talk, and we will learn what we have learned from COVID-19. Thank you very much.
So thank you very much, Chairman, and thank you people for attending what I think will be a very exciting session. So non-invasive respiratory support, what have we learned from COVID? I've put on the slide here a short list of conflicts of interest. The only relevant conflict of interest is funding from the Department for Health in the UK, which supported the Recovery Respiratory Support Trial, which will be presented as part of today's talk. So looking back to where the evidence base sat prior to COVID, early after the recognition of COVID, this pivotal systematic review was published in January. It was a systematic review, a network meta-analysis that pulled together all of the studies that had investigated the use of non-invasive ventilation amongst patients with hypoxic acute respiratory failure. And it was quite timely that these data from a non-COVID setting were presented and shared. You can hopefully see over from the left-hand side of the slide, 25 randomized controlled trials with 3,500 patients. The studies evaluated face mask non-invasive ventilation, standard oxygen therapy, high flow and helmet non-invasive ventilation. Here's the summary findings from that pre-COVID review, and the top part of the chart looks at the impact of those interventions on mortality, with face mask non-invasive ventilation and helmet non-invasive ventilation demonstrating evidence of a mortality benefit, and for a reduction of intubation, all three interventions modalities reducing the need for intubation. So fast forward from the publication of that review, we then around the world were faced with a tsunami of patients presenting with severe acute respiratory failure secondary to COVID-19, and systems were stretched and required to respond to the global pandemic in ways that few, if any, had encountered prior in their professional careers. There were several considerations in terms of the treatments available, and I think this did evolve as our learning evolved through the pandemic. But the four main routes for respiratory support were controlled oxygen therapy, non-invasive ventilation or CPAP, high-flow nasal oxygenation, or invasive mechanical ventilation. And the evidence base was one component driving decision-making, but there were also other important components driving decision-making, both at the early stages and as the pandemic progressed. And this related to the availability of equipment, the availability of oxygen, and the infrastructure within a hospital to actually deliver the oxygen to patients, with each of those being a challenge across many health systems. This slide, I think, is reflected across a number of health systems. These are data from the UK Intensive Care National Audit Research Centre, and it shows the pattern of respiratory support as the pandemic progressed. So at the bottom, you can see the number of patients admitted to intensive care in the various different ways at the pandemic. And you can see early on in the pandemic, there was a tendency, or a very high proportion of patients admitted to intensive care received invasive mechanical ventilation. Some of that, I think, was driven around uncertainty about the safety and effectiveness of non-invasive ventilation. There were also concerns about the potential risk of viral transmission through aerosol-generating procedures. But there were also capacity constraints that meant that often only the most sick could come into our intensive care units. But what you can see over the course of the graph, that the proportion of patients requiring invasive mechanical ventilation reduced, and the severity of their illness indicated by the FiO2 and the mean PaO to FiO2 ratio, that patients became less physiologically stressed upon admission to intensive care. So through the remainder of the talk, I'm going to consider two contexts for the non-invasive ventilation strategies, where it's being done as part of an active treatment plan to prevent intubation, and then we'll just touch at the end around the group that it was used as a part of a ceiling of treatment plan in people who were not considered suitable or had requested not to receive invasive mechanical ventilation. So I'm going to start off by looking at the evidence for high flow nasal oxygenation versus controlled oxygenation. And if I was giving this talk 2 years ago, it would be a very simple talk because it would be finishing at this point by saying that there are no randomized controlled trials that can guide our practice. But we're very fortunate that around the world people came together to actually conduct research in a highly challenging setting. And actually now we've got a good body of evidence that helps inform our treatment of patients with COVID-19. One of the first studies to publish was the high-flow COVID randomized controlled trial, and many of these studies have been published in JAMA. This was a relatively small study recruiting just 199 participants from emergency departments and intensive care units with moderate to severe COVID. The study was conducted in Colombia, and it had a combined primary outcome or co-primary outcome of need for intubation and time to recovery. You can see from this slide that in this study, high-flow nasal oxygenation was effective at reducing the need for intubation and also showed evidence of benefit in terms of clinical recovery, with the group recovering more quickly, on average 3 days quicker in the high-flow oxygen therapy compared to the controlled oxygen therapy group. We conducted the recovery respiratory support trial. This was an adaptive trial that allowed sites to randomise on the basis of the technologies available at the time. So they had the option of randomising to CPAP, high flow or controlled oxygen therapy, and the randomisation then allocated on the basis of the available resource. This study had a composite outcome of tracheal intubation or mortality within 30 days. We recruited 1,260 patients across 48 hospitals in the UK. So the findings from this study in relation to high-flow nasal oxygen versus controlled oxygen therapy, you can see over on the left-hand side, there was no significant difference in the composite outcome of intubation or mortality within the first 30 days. If you move over to the right-hand side of the slide, you can see the components of that composite outcome broken down, and there was no difference in intubation or mortality. A subgroup analysis defined a priori, identified that potentially those with less severe illness, so with an FiO2 of less than 60%, that there was some evidence of interaction there, suggesting that potentially patients with a milder requirements for oxygen therapy may potentially benefit from high-flow nasal oxygenation. The COVID high study, again, another large trial, 364 patients across 27 countries. This recruited a slightly milder cohort of patients and randomised to high-flow nasal oxygen or standard oxygen therapy, and found no difference between the two interventions, similar to the findings from the recovery respiratory support study. The final study to address high-flow nasal oxygenation versus controlled oxygen therapy was the COVID ICUs study that was conducted from 19 intensive care units in France. This was a factorial designed study that included randomization to high or low dose dexamethasone, high or standard dexamethasone, and then a secondary randomization for those not intubated to high flow CPAP or controlled oxygen therapy. And as you can see over on the right hand side of the slide, there was no difference in the proportion of patients that met criteria for invasive mechanical ventilation at day 28. Moving on then from the summary of high-flow nasal oxygenation to CPAP. So the other part of the recovery respiratory support trial randomised 380 patients to CPAP and 475 to controlled oxygen therapy. The design of the study was otherwise similar to that presented a few moments ago. And unlike high-flow nasal oxygenation, this study demonstrated a significant effect for the primary outcome with a reduction in the composite of intubation and mortality that was statistically significant. And over on the right-hand side of the slide, you can see that the breakdown of that composite, that it was driven almost exclusively by a reduction in the need for invasive mechanical ventilation. The COVID ICU study, you'll recall that this was the factorial study from France. This study found no difference between, and this should read CPAP versus controlled oxygen therapy. Moving then to the comparison between devices, and the evaluations here are more limited. We are doing some work with the investigators of many of these studies to pull the data and undertake an individual patient data meta-analysis to try to unpick the effects of different interventions, and that work continues in progress. The recovery respiratory support trial that I've alluded to was not designed to directly compare between the two interventions. It was designed to compare to controlled oxygen therapy, so that's not included in the evaluation here. Again, one of the early studies to report was the Heavy Knot study. So this was a small randomised controlled trial from 4 intensive care units in Italy fairly early in the COVID pandemic, and it randomised 54 patients to helmet ventilation and 55 to high flow oxygenation. The left-hand side of the slide is the primary outcome, which is the median respiratory support free days. And whilst there was an absolute difference of 2 days in favour of helmet ventilation, that didn't reach statistical significance. But over on the right-hand side of the slide, if you look at the cumulative incidence of intubation, that you can see that compared to high-flow nasal oxygenation, helmet non-invasive ventilation was more effective. The helmet COVID study was a study which randomised 322 patients to helmet non-invasive ventilation or usual respiratory support. And the usual respiratory support was a mix of interventions. It included mask non-invasive ventilation, high-flow nasal oxygenation and standard oxygen therapy. So a little more difficult to pull out a direct comparison between interventions. It was conducted in 8 intensive cares in Saudi Arabia and Kuwait, and the primary outcome was 28-day mortality. And what you can probably or hopefully see here is that in terms of the primary outcome, no significant difference in mortality. Whilst there was early separation of the curves suggesting a higher rate of intubation in the usual care arm, this crossed over at about 12 days and was not significantly different between the groups. The final study comparing high-flow nasal oxygenation versus non-invasive ventilation was a study from India. It randomised patients, relatively small numbers, to high-flow nasal oxygenation or non-invasive ventilation. And you can see over on the left-hand side of the study a pattern towards reduced rate of intubation at 48 hours and a pattern towards reduced mortality in the high-flow nasal oxygenation group, but numbers are relatively small and the confidence intervals include 1, so therefore no statistically significant difference in the context of that study. So in the remaining couple of minutes, I've just got 2 slides on the right-hand side, which is around the ceiling of treatment. And as I guess in this difficult situation, there have been no randomised controlled trials evaluating different non-invasive ventilation modalities where one doesn't have the opportunity to escalate to invasive mechanical ventilation. But there have been a number of observational studies. This is a systematic review through to February 21 that summarised the effect of non-invasive ventilation strategies in this not for intubation group. And I think that there are two key take-home messages from these studies. Firstly, that 1 in 4 people assessed in these observational studies were classified as not being suitable for invasive mechanical ventilation. And then over on the right-hand side of the slide, you can see the proportion dying, really a very high mortality rate in the group of patients considered not suitable for invasive mechanical ventilation. This was a UK-based study undertaken from 7 hospitals in the north of England. And again, I think this provides some useful data by comparing CPAP and oxygen in the not for intubation group. And I think one of the striking things here is the proportion of patients that didn't tolerate the treatment, which I guess may be reflective of their underlying comorbidities and challenges. And there was no significant difference in the outcomes of the duration of oxygen therapy or the requirement for CPAP between the 2 different groups. I guess suggesting that ward-based CPAP as a ceiling of treatment is probably best based around a conversation with the patient and an evaluation of their response to treatment. So it can be difficult to pull all of this evidence together, and so I guess when I've tried to think about how I pull all of this information systematically, then I think of identifying patients who have evidence of respiratory impairment on the ward, that then one needs to consider patient factors in terms of their frailty, their COVID severity, comorbidities and patient preferences, but one also needs to be mindful of the resources that are available, and then dependent on the outcome of that, one would undertake a trial of CPAP or high flow nasal oxygenation with an a priori plan as to what would occur in the event that the patient doesn't make progress with that particular intervention. So take-home messages, I think that non-invasive ventilation modalities have a significant role in the treatment of COVID-19, that the treatment plan determining whether they're for escalation or what the plan B is in the event that it's not successful is really important. I think that the evidence points towards CPAP being more effective than high flow nasal oxygenation, but that's my sense of the data as a whole rather than having analysed that systematically. High flow nasal oxygenation, I think the evidence is less certain, but in many situations it's actually a combination of the 2 treatments, with patients perhaps receiving a mainstay of treatment on CPAP and then crossing over to high flow nasal oxygenation during feeding and washing and during the weaning phase. Thank you very much for your time and attention.
Thank you so much for this beautiful overview. So do you have any questions? So we have learned so much from COVID, and then my question would be, could we just also use all this knowledge for the non-invasive ventilation of a patient with bacterial community-acquired pneumonia, for instance? Would you directly apply it to those patients?
So I think it's really difficult. So I think the disease is different, and I guess a patient with severe ARDS driven by a community-acquired pneumonia is probably similar to somebody, is closer to COVID-19 than somebody that has a lobar pneumonia. I think the evidence that has picked out pneumonia as the specific cause, is much more limited. But I guess if we reflect back to that systematic review and network meta-analysis that came prior to COVID, there were certainly patients within that who had an underlying pneumonia as the cause of their acute respiratory failure. I guess it's a group where the evidence is uncertain, and where there's uncertainty, it's likely okay to try it, but with a low threshold to escalate and with appropriate monitoring in the event of deterioration.
Yeah. Makes perfect sense, I guess. Well, all right. Thank you very much. Then we move on. Thank you very much.
So it's my pleasure to invite to the podium the next speaker, which is Professor Massimo Antonelli from Rome, Italy, and he's going to discuss about non-invasive ventilation for patients with respiratory failure.
As first, thank you for the introduction. As first, I have to sincerely thank my good friend Gavin, because he showed a large part of my slides, and then I can just stop my presentation here. I'm ready for your question. I'm joking. Of course, I'm joking. I will try to give you a different perspective. These are conflict of interest. My idea is just focusing on the de novo acute respiratory failure. If you prefer, we can call them RDS. And if you look at the consensus conference that developed the new definition of RDS, in 2012, there was this graph that illustrated the various possibilities of intervention in these patients. And the non-invasive ventilation, I added the high-flow oxygen therapy, were allocated for the milder cases. But we know very well what happens during the pandemic. We have treated, because of necessity, because the lack of beds, we have treated very severe patients outside the ICU to start with and moving them as soon as possible. And then we could I remember having treated patients whose PF was below 100, starting in a ward, and thereafter, as soon as the bed was available, moving them to the ICU. However, if you look at the suggestion given by the guidelines, it is indicative and very interesting that the main question, if it is usable or not in de novo acute respiratory failure, is indeed a recommendation that give back uncertainty, because there is no possibility to give a recommendation. But why? Because the evidences specifically dedicated to this issue are very few and not sufficient for delivering a recommendation. However, the rationale in this recommendation was interesting because it is alluding to three different points. As first, for those groups who are indeed keen in this technique, they can use it, and they at least giving a trial of non-invasive ventilation to these patients, and the experience of the team, especially over the year, when you gain that, it's really very important. However, my intention is just to try to address some of the knowledge gaps that we have in the various forms of non-invasive ventilation. Starting with the high-flow nasal cannula, we know quite well that we are always stressing that we can have an increase of the end expiratory lung volume, of the recruitment and lung compliance. But indeed, there is no real study that can tell us clearly how important may be the recruitment and how important is the capability of improving lung compliance making measurements. In addition to that, it is interesting also to remind that as soon as you have a patient who is on assisted pressure control or in pressure control ventilation without spontaneous breathing, the pendulum, so the oscillation of the volumes inside the alveoli may vary a lot. And this can be this way when there is a spontaneous breathing, various dishomogeneous, whilst it's totally different the distribution of the pendulum when we allude to patient is breathing in controlled mechanical ventilation. But this means also that we do not know how it may increase, how, for example, the high-flow oxygen therapy may correct that, how, respect to the high-flow oxygen therapy, other forms of non-invasive ventilation may improve. We started of having some evidences. I put there one of our articles published last year, where we try to compare the high-flow oxygen therapy, helmet CPAP, helmet non-invasive ventilation, in order to answer the question if there were improvement in terms of dynamic strain, Penderluft, quasi-static compliance, and you can see that there are, in large part of these parameters, an improvement as soon as non-invasive ventilation, namely pressure support ventilation, has been used in comparison to high-flow oxygen therapy. And if you look at the Penderluft, and you look at the first, and the panel in the left, this is the panel that represents the regional Penderluft during the high-flow nasal cannula. If you compare this regional Penderluft to the one that you can see when the patient is breathing through an helmet CPAP or helmet pressure support, this is much more. So it is something that we have to take into consideration, and we need to go deeper into this idea in order to better understand the dynamic phenomenon. And this guideline, however, point out how should be used extensively in the hypoxemic respiratory failure, at least in the early phases. But if this is true, and it has been also applied, this is one of the first studies from the French group, and the Reva network. Jean-Pierre Fratt is the first author, where was studied the effect of high-flow nasal cannula versus the standard oxygen on mortality. Maybe mortality was not the best endpoint. However, if you look at the final results of this study, enrolling a consistent amount of patients, all with a PF below, almost all with a PF below 150, and look at the mortality rate at 28 days, there is no significant difference in terms of mortality between the two groups. So, at least looking at this endpoint, and we may put a question mark, is that one the best endpoint we have to look at? But there is no difference. However, in looking once again to the cumulative incidence of intubation with respect to the baseline, you can see that those who receiving the high-flow oxygen therapy were intubated less with respect to those receiving the standard oxygen. Then I don't want to insist that much on our study that is focused on COVID-19 and once again comparing the non-invasive ventilation delivered through the helmet to the high-flow nasal oxygen. And these are the negative results apart the intubation. But the goodness of this study is that despite the limited number of patients, these two groups of patients were receiving exactly the same therapy. And you can know that a pharmacological therapy at that time was not so clear. Having two groups very homogeneous strengthened the goodness of the final results, at least in terms of endotracheal intubation. Then we have the one that also Gavin was alluding to, the COVID-19 study, the helmet COVID conducted in Arabia and in the Arab Emirates. And even there, you can see that despite the dishomogeneity or the complexity of the control group, where various forms of respiratory assistance has been used, for example, mask, non-invasive ventilation, high-flow oxygen therapy, and oxygen therapy, there was no difference in terms of mortality. But we can explain also no difference in terms of intubation for these patients simply because in comparison to what we have seen in our group in the HENIPOT study, the application of the non-invasive ventilation, and this is another message, was later. And of course not in the early phases, so the response is different. And on top of that, there was also a sort of dishomogeneity or a large variety of approaches into the control group. Another question. We have spoken a lot about the high-flow oxygen therapy. Maybe something that can be used in a prone position. May it represent a benefit for these so serious patients? The reason why we may get a benefit from the prone positioning are summarized into the slide, and go from the shift of ventilation toward the posterior dependent lung region up to the reversal acute cor pulmonaire. And there are interesting data coming from the literature. This is a meta-trial group, is a specific way to approach the problem from various observational studies, but where we had a large number of patients, more than 500, and who were put prone for at least 6-8 hours. And interestingly, in all these patients, I know that this is a group of observational studies, but the signal there is strong. And as soon as they were put prone, 30 minutes after the prone positioning, they immediately improved their PF, the ROX index, and the peripheral oxygen. And the treatment success was proportionally higher when the prone positioning was longer. So it's something that we have to consider. Having no difference in mortality once again in this specific study, but a reduction of the treatment failure for those who were put prone respect to those who were indeed not on that. We have another open question. We are speaking a lot about the use in these severe patients, also in other kind of patients, the high-flow oxygen therapy as a sort of palliative care. We don't have any answer respect to the benefit in terms of comfort of the patient and for those who have an acute respiratory failure and do not intubate others. But this multi-center perspective study that is ongoing in France, I guess they will give another answer to our multiple questions. Which are my conclusion? So we can leave a large body for your questions. The high flow and non-invasive ventilation may be used for mild to moderate LDS patients. The clinical practice during the pandemic extended its application in and outside the ICU. I guess that if I ask you how many of you have used diffusely this technique also outside the ICU, maybe at least all those who have treated COVID-19 patients may raise up their hands. Then it's also, okay, we can try. So, raise up your hands, all those who treated these kind of patients. It is certainly helpful for concern the high-flow oxygen therapy. However, even though we have some clues, we have some responses looking at the various studies, still there is no clarity on which one of the two techniques is better. And probably, as I am always repeating, looking at the non-invasive approaches of these patients, the combination of the various techniques may be an option. In the same patient, for increasing the tolerance, just moving from, for example, a trial of non-invasive ventilation with a helmet, then you stop, you use high-flow oxygen therapy. After that, the patient may have a rest and you can use a mask, non-invasive ventilation, and so on. You need to be imaginative in this case. I understand that there are still a number of unanswered questions, but these only have to push us in exploring more some of these fields and areas. And certainly there are potential gaps, as I alluded to, in the fields of physiology and finally the palliative care. Thank you for your attention.
Thank you, Massimo. Very clear and precise presentation. There is one question in the third row, please.
Hi. I would like to ask you, what do you think about the fact that in most of these trials, they use invasive ventilators as a non-invasive ventilator mode, and they didn't use a non-invasive ventilator as a...
Does it make any difference?
I'm asking because I have been reading that the capacity to compensate leaks and the time to assist is different. So
you are in part right in the sense that what you're saying was absolutely true in the past, and most of the dedicated ventilator to the non-invasive ventilation were turbine driven, so more efficient. But these gaps are totally compensated nowadays because any of the ICU ventilators are capable to assure that. In one of the hands-on session, I showed how, at least with the modern ventilator, you can deliver an efficient CPAP. We always looking at a rotameter and the free flow CPAP, but can be done very efficiently, exploiting some of the modalities of the modern ICU ventilator offer. I'm speaking about the high flow oxygen therapy modality. You shift the mode to high flow oxygen therapy, you connect giving more than 50 liters per minute to the helmet, for example, and you use the other port, the other limb of the helmet, placing there a CPAP valve, a spring valve, and it works. Also because what was the prerogative of the previous ventilator is not so essential anymore. And consider also that you have also something that is very important, that you have with the modern ICU ventilator, the compensation of leaks. Yeah. Very efficient.
Thank you.
Any other question?
Elie, you don't have any question. That's why. So you are answering the question that you would like to ask me with your lecture, I see.
I have one question, Massimo. You explained very well that during the pandemics there is an extension of the use of high-flow nasal cannula outside of the ICU, maybe also awake proning outside of the ICU. But for other conditions different from COVID, that maybe RDS from any other reason, that maybe secondary RDS in a patient with peritonitis, for example, what do you think about that? So it's...
Of course, you can have some limitations.
Yeah.
If you have a patient with peritonitis or who underwent a surgical operation, an abdominal surgical operation, maybe not a right candidate to use or to propose the prone positioning. But for pneumonia, the real truth that for the moment, here and there, various groups are collecting data, but we do not have any systematic paper and investigation anymore. I'm sure, knowing how efficient are our French friends, that somehow the Reval Nectar has into the drawer a new study that will answer the question. But for the moment, no one is at the horizon, to my knowledge.
No, my concern is that we underestimate the severity of those
I
patients
guess so.
with different conditions like COVID.
I guess so. But there are really a number of question marks. Think about in the past, not anymore. We have extensive use for unilateral infiltrates, also the side position. And it worked. Then all the research concerning this specific aspect was abandoned. It's a time to revamp, at least for the cases that you were alluding to, that I don't know. But still, even though a bunch of literature has been published in this field, still there are no question marks.
Thank you. I think it's an excellent way to closing this conference. So we are moving.
And so you will answer the question that you want to ask me.
You already saw the next speaker, so welcome to the floor to Dr. Elie Azoulay, Professor of Critical Care Medicine from Paris. And he will learn us how to avoid endotracheal intubation in the immunocompromised patient. Thank you very much.
Thank you very much, and thank you, Massimo, for the introduction, because there are a lot of concepts in immunocompromised patients that Massimo knows very well. He has been the one leading the field for years and even now. But there are striking differences that I would like to share with you. These are my disclosures. So in terms of oxygenation and ventilation, one, we have a menu that is quite clear. We can use the simple nasal cannula, the face mask, the face stent, because they still exist, the venturi mask, the non-rebreather mask, and the high-flow nasal cannula. All these systems only provide oxygenation. They are not improving ventilation, so they are used in hypoxemic acute respiratory failure. And we have this system, and I'm going to explain you why, personally, and in the experience of myself and my group, I don't use non-invasive ventilation anymore in immunocompromised patients. Not because it's harmful for the patients, because maybe what we are expecting from it has not been demonstrated in the literature. So this is a paper from my group that was published in 2015. It's a randomized, of course, open controlled trial involving 374 patients who received either NIV or oxygen. And as you can see here, in terms of survival and on non-invasive ventilation, it didn't make anything. So this is NIV as compared to standard oxygen. Now, very recently, the group from Center-West France, did another study where NIV was compared to high flow nasal oxygen. So patients had either high flow or high flow plus NIV. Almost 300 patients, and the primary endpoint was mortality. And here again, no significant difference in terms of intubation and no signal in mortality, not in the overall population and not in subgroups. If we combine this data to all the things that demonstrate that in the deeply hypoxemic patients, and Massimo has been very careful by saying mild to moderate ARDS, maybe the question of using NIV might be harmful is the most hypoxemic patients. But you could say, but still, there is no harm from these studies, and this is true. But still, we know that there is some patients presenting NIV intolerance, that we know that NIV can induce anxiety, that we know that there are a very good description of NIV disengagement. So I believe that all of this is certain, but it's also very much center dependent, based on the experience and the patience of healthcare providers to provide NIV, and at the same time on our ability to pay attention to some details like minor and major complications from NIV. And we know that NIV failure is certainly not related to the technique, but to the underlying severity. But we also know that there are many papers reporting on the experience of NIV. That being said, we know that there are side effects, but there are also side effects from prone positioning that are almost the same. But still, we know that it's not a simple technique, and this is the traumatic complications. Very recently also a paper from the group from Samir Jaber publishing in a large number of patients receiving NIV, a very small but an existing incidence of cardiac arrest. Again, I don't believe that NIV produced cardiac arrest. I believe that we have pushed NIV maybe too long. It's 1 per 10,000 cases. So it's still very low. Now, there's a question mark about CPAP. Well, again, we are now piloting to learn about CPAP and helmet because you have in Italy a huge experience since the 90s. We don't have. In our hands, we are trying to understand the patient's experience. So this is a trial that rose a lot of questions. So is there now a place to evaluate CPAP? We are considering this in immunocompromised patients, but we need to pilot and to be able to report on something for which we have the experience. Now, about high-flow nasal cannula, as you know, we cannot provide high-flow oxygen without providing warm oxygen and humidified oxygen. That being said, when we compared NIV to oxygen, a group of patients had high-flow and not standard oxygen. So we did a sub-study from this trial where 127 high-flow patients were compared to 226 standard oxygen patients, and there were no significant differences. So we were able to at least raise the hypothesis that it was equal, and we had the equipoise. It was very different as compared to the sub-study from the group of Jean-Pierre Frat. So they took from the Florali paper 82 patients who were immunocompromised, but not neutropenic, and they compared the three groups. And as you can see, the differences are very high, are mostly related to an increased mortality in patients with NIV, something that the recent trial didn't demonstrate. So these results, well, provided us with the feeling that we needed to do, and this is about intubation. A specific trial. So first we piloted that by just in the group trying to understand the criteria and the outcome measures. So this was a two-hour trial in immunocompromised patients with acute hypoxemic respiratory failure, and there were no differences in terms of oxygenation and in terms of comfort. So we really thought that we were able to do a randomized controlled trial. Between this time, with a group, with colleagues from Italy, from Spain, from Portugal, from many different countries, actually 16 countries, we did an observational study with 1,611 patients with hypoxemic respiratory failure who were immunocompromised. As you can see here, 57% of the patients were not intubated at admission. And you can see here that there were no differences according to whether they were receiving NIV, standard oxygen, or high flow oxygen. And of course, unless the patients were intubated first line, no differences in terms of mortality. So looking at this data, the trial that we did that includes 776 patients immunocompromised, receiving either high flow or standard oxygen, because the NIV trial was negative. So we took the same primary endpoint than the Florally trial, mortality, and then intubation and other endpoints. So you can see here the two groups randomized with little patients lost to follow-up. I think I'm moving too fast, and no differences between the two groups. And as you can see here, this is the mortality probability. It is really the same, and there is. I don't know why the intubation plot is not there, but still there was no significant difference in patients receiving, with regard to intubation. There was a difference of 7%. All my slides are moving without me, but it was not significant. So this is the systematic review and meta-analysis from BRAM, showing that there was no difference in mortality, but when we pull all the studies, there's a difference in terms of intubation rate or of escalation of therapy. And these are the forest plots for the two outcome variables. So that being said, there is just a message that is, to my view, important to pass. So this is another study with individual patient data analysis, a large study, 11,000 patients, 24 studies, 3 trials, and 21 cohorts. So everything is pooled with 74% patient intubated. So I just want, and I think that a lot is here. One is, look in the left part of the slide, how mortality evolves over years. So we start in 95, where mortality of intubated patients were already not 100%, it was 65%. And at the end, so in 2017, it was 45%, and now is very close to 40%, and in some studies, even 35% if the patient is not in multiple organ dysfunction. And the right part of the slide provides the difference of mortality rates according to the number of days between ICU admission and intubation, because all of those patients were ultimately intubated. And you can see here that the more you're taking the time to intubate the patients, and then their mortality is higher. So this brings us to many different concepts that would need to be further explored, because this is very nice conceptually. There are hypotheses that take this to the reality, but we still need to demonstrate that based on that, we are able to really tailor a treatment with regard to the expiratory tidal volume. So of course, when we look at the respiratory drive of these patients and how when they are spontaneously breathing, we can see that they are receiving volumes that we would never prescribe. And those volumes might produce themselves another lung insult, aggravating the initial injury. So this is a concept, and the concept is not only smart, but also has some hypotheses supporting it, but we need to understand whether future studies should not only stratify on how much important is the drive and whether we can control it. Should we leave patients with 900 milliliters of expiratory tidal volumes? I don't think so. And we know that these patients remaining tachypneic with high VTEs are those patients who are going to get intubated. So how can we use this smartly to then select the appropriate population for receiving maybe a combination of high flow and non-invasive ventilation? Thank you.
Thank you so much for this clear presentation. Any questions from the audience? Yes, of course. Thank you.
Elie, one of the things that has been not mentioned, but is a fact, that also the outcome of the immunocompromised patient changed a lot over the years, consequently to the improvement of all the therapies.
Very true.
And so it's not 100% so easy to interpret this data. This is my first comment.
We can interpret the trials because
Yeah.
they were done within 9 months. We involved 800 patients within a very short time period. And from what we can observe with those trials, there is nothing to support that. Where we are really aware that there is a frailty in those results is on the ability that had the group to provide that. The other thing is that I have no belief, and absolutely no belief in PF ratio in spontaneously breathing patients. So they certainly have RDS, but I would not pay so much attention to that. And that being said, we cannot compare those patients over time. They die less, that's obvious. And looking at the big picture, I agree with you, we cannot draw any conclusion. But looking at the trials, we can at least say that the effect is not so obvious.
The only comment I want to make, which is somehow technical and can suggest a solution to the potential risk of the CILI, of the self-induced lung injury. What we do, at least in patients receiving the helmet non-invasive ventilation, and where we could use higher level of PEEP respect to any form of non-invasive ventilation, we introduce for enteral feeding, but for measurements of the transpulmonary pressure, the esophagus catheter that offer us the opportunity of measuring the transpulmonary pressure. And this may make the difference, even though you cannot measure reliably the tidal volume on the display of the ventilator, because it's a sum of the volumes that we are giving to the patient and to the ventilator. Nonetheless, as soon as you record that you have a too high transpulmonary pressure, maybe this is a patient where we should go right away on intubation.
So this is what I was calling the smart way
Yeah.
to use this physiological data to guide the practices.
I have another question. So this group of immunocompromised patients, of course, is extremely heterogeneous. So in your studies, could you also stratify for certain specific subsets of patients who are immunocompromised?
So yeah, this is a very good point. So of course, immunocompromised patients is wide. We are now working on phenotypes, and we are working with Matthew Komorowski in London to analyze what would be the subgroup of patients in whom we would have good results, and maybe the group of patients in whom we should be more careful. And we are into that, and we are now identifying a group of patients with a very clear benefit of NIV, and another group of patients with a very clear benefit of high-flow nasal oxygen. I just remind you that in these studies, we had only hypoxemic patients, no pulmonary edema, and no hypercapnic patients. So
do you identify those subsets, those endotypes with clinical phenotypes, or do you also use a multi-omic transcriptomic approach?
It's more than clinical because we are also introducing some inflammatory variables. And I would say that the addition of those inflammatory variables are very little adding to the algorithms. But you know, we are now with the conceptual model, so we have one cohort of 1,600 patients and another group that is the accumulation of the trials. So we are validating that, and for now we are working on that. So I wouldn't give, but yes, you are right. There are a group of patients that for which we can expect that the results are different than for others. And we're looking at malignancies versus other patients, also looking at the acute respiratory failure etiology, whether pneumocystis pneumonia would respond differently than aspergillus or a bacterial pneumonia.
You can imagine that, yeah. Okay. All right, so we thank you very much once again.
So next topic we are going to discuss is back CPAP as a new option by Jean-Christophe Richard. Jean-Christophe is coming from Angers in France.
Thank you very much, Mr. Chairman. Ladies and gentlemen, my pleasure to contribute to this very interesting session. I will focus my talk on this new solution for CPAP that will address respiratory failure, but also in constrained environment. As you remember, my conflict of interest, I share my working time between the university hospital, but also Air Liquide Medical System, where I work with young engineers on new solutions for ventilation and also for cardiac arrest. The idea is to discuss again CPAP, but in this constrained environment that we experienced during the last pandemic. As you remember, the world experienced during the COVID crisis a lot of oxygen shutdown in different places in the world. First, because of the huge number of patients with high FiO2 requirement, but also because we use several techniques and non-invasive techniques consuming a lot of oxygen. So, with our colleagues of Henri Mondor Hospital, Guillaume Carteau and Armand Meconso-Dessap, during the pandemic, we tested the possibility to use the Bousignac system, which is a very simple single-use CPAP, which is working as an open valve. There is a small illustration on the slide that show you that the system is based on the connection to the flow meter, and because of the entrainment of ambient air, the system is able to increase the FiO2 and maintain a positive end expiratory pressure with a very low work imposed by the system, meaning that the system is very well tolerated by the patient, except for at the exception of the noise, which is very, very high. So we experience this system to extend the possibility to manage ventilation in this patient outside the wall of the ICU, and we also tested on the bench, showing that this system is working perfectly. This use of the CPAP was, as discussed this afternoon by Gavin Perkins, supported by recent data suggesting that CPAP could be very efficient in the treating of acute respiratory failure of COVID patients. In this context, we decided to develop a new system, a new solution to address the need of CPAP, and the purpose of our innovation was to generate a CPAP with a very simple single-use system. The purpose of the new bag CPAP was to maintain a PEEP at 5, 7, or 10 centimeters of water, depending on a very simple single-use spring CPAP valve. And in addition, the idea was to guarantee a FiO2, either mild or moderate FiO2, 50 to 60%, using 5 liter minute oxygen flow meter, using a Venturi system that again permit to entrain some ambient air to maintain the pressure in the system. Or a high FiO2 between 90% to 100% that could be reached with 10 to 15 liters per minute oxygen, depending on the demand of the patient. The idea is not completely new, and I'm sure that Massimo remember the first reservoir CPAP in the past, but these reservoir CPAP in the past were not done to reduce the oxygen consumption, but much more to maintain the pressure. So it was elastic reservoir for invasive ventilation. The system that we developed with Héloïse de Beaufort, my young PhD working with me in Air Liquide Medical System, is a soft bag with the idea that when the patient is disconnected from the mask, the bag is still with oxygen, and then you could resume CPAP without the need to pressurize again. So we developed very rapidly during the pandemic this system, and we decided with our colleagues on Angers, on Mont d'Or, to test it on a bench model. This is an illustration of the FiO2 according to different simulated respiratory demand. This is a moderate and then a high respiratory demand simulated on the bench. And you can see that with the Bousignac system, the open valve, this is the blue line, you can see that the FiO2 is very high, but there is a drop in FiO2 as soon as the demand increases. Just the result of the entrainment of ambient air when the patient is in respiratory distress with the open valve system. On the opposite, with the bag, you can see the green line with the high FiO2. The FiO2 is completely maintained, whatever the demand, above 90%, just because the patient is breathing the mixture from the reservoir. And if the reservoir is not empty, the mixture is guaranteed and the FiO2 is absolutely guaranteed. You can see that it's quite the same for the moderate FiO2, again, suggesting that this system is very efficient to guarantee whatever the demand, the FiO2 with a low oxygen cost. We measure several systems with this specific setting, with a very realistic head, a mannequin head, and we try to compare different devices. We compare to a ICU ventilator just as a gold standard, and we compare different systems. This is two open valve, another system which is a Venturi mask with a Venturi, and the back CPAP on the right. The left panel illustrates what happens when we simulate a moderate respiratory demand with the setting for all the CPAP tested done to obtain a FiO2 between 40 and 60% and a PEEP level in between 5 to 10 centimeters of water. And as you can see, we can reach the PEEP level with a different system, but the price is that the FiO2 in case of with this respiratory demand is relatively modest FiO2 compared to the highest value obtained with the back CPAP, and the red circles illustrate the ratio between the FiO2 and the oxygen consumption. The higher is the red circle, the higher is the efficiency of the system in terms of FiO2 consumption of oxygen. The right panel illustrates the same system, but at a higher FiO2 level, obtained with higher oxygen delivery. And again, the back CPAP was the system the more efficient to save oxygen and guarantee the highest FiO2. So the question is, what about the tolerance of the system? Because there is no magic device. And in fact, we look at something very important that very well known by people working on physiology, on mechanical ventilation, which is the work of breathing. This is not the work of breathing developed by the patient, but the imposed work by the device, meaning that if the system is highly resistive, the work of the patient will be very high, and the tolerance may be bad. So we compare using this pressure volume curve, is a current way to assess work of breathing, the different system, and the red loops is obtained with the ICU ventilator, which is a gold standard. You can see inspiration inspiration, expiration. And as you can see, with the bag CPAP or the open valve, the work is a little bit, but significantly higher compared to the ventilator. This is observed with the same oxygen flow, but if you decide to reduce the oxygen with the bag CPAP to limit the consumption, then the price to pay is an increase in the work of breathing and maybe a bad or worse tolerance for the patient. This is what we observe in a pilot clinical study done in Henri Mondol Hospital and in parallel in Angers University Hospital with a special authorization for the regulation authorities and the ethics committee because the system is not yet CE mark. And this is a study in 20 patients with acute respiratory failure in the emergency department with COVID or non-COVID causes. And what we observe is that in some patients that require the moderate FiO2, this is the oxygen consumption. You can see that with 5 to 10 liters per minute, we manage all these patients with the FiO2 above 50%, which is very high compared to the consumption. And in some patients, we reach, because they need, because of their respiratory failure, to increase the FiO2 above 90%, and we obtain this FiO2 with oxygen flow from 12 to 20 liters per minute. This is the observational result of this study regarding the SpO2 and the Borg scale to address the tolerance on the system. And we were surprised about the good tolerance for all these patients. And interestingly, we were very surprised by the acceptability of this new system by the nursing staff in 2 different university hospitals. So this research is inside a project of development that is run by Armand Meconso de Sape, an technological innovation for frugal innovation. And we are currently working on different systems, the bag CPAP, but also an open valve, which is named Mondor CPAP, which is a little bit adapted in order to better balance the PEEP and the oxygen consumption. I thank you very much for your attention.
Any question from the audience? Yes, please, Massimo.
Very quick question. As first, what is the maximum level that you can achieve, a level of PEEP with the system? The one that you have shown into the graph, 7 or something like, or can you achieve a higher level?
We can choose because we use a spring CPAP valve. So we have 2 types, one different valve or one valve with different level of CPAP.
So you can modulate.
Yeah, absolutely.
And the second thing, have you ever thought about the possibility of using this system in the ambulance?
So we not tested really in the ambulance, but what we observe is that it's perfectly adapted to transfer the patient inside the hospital, in the city, or it's very simple because you can put the bag on the bed and there is really simple. But probably it could be used in the ambulance. We have to test that. It's a good... Yeah.
So, in fact, I have the same question, which is beside COVID situation, which is the future applications you are expected for the bag CPAP?
Of course, the idea comes from the COVID crisis, but for us, it could be very interesting in other constrained environment. And for example, in in a flight. If you need to manage a patient with oxygen for 3 or 4 hours, it's definitely not possible because there is no sufficient quantity of oxygen. This system is very easy to use in that situation, or other constrained environment in the ambulance or in different situations.
Okay. So if we are no more questions, we are going to proceed with the next presentation. Thank you.
Thank you.
So I think Giacomo is not in the room because he's teaching in another session. So we will move to Francesco Mojoli if he's here. Not Francesco. Adrienne is here. Adrienne Randolph. No? Any speaker in the room? No. Speakers are busy, so we wait for you. So no rush, Giacomo. So next speaker is Giacomo Grasselli.
Yes.
You can breathe some air, maybe CPAP or high flow, or no, not necessary, I think. Is the helmet the perfect interface?
Yes, just a second. Oxygen, I need oxygen because I ran through the stairs from all 100. Okay, thank you. Conflicts of interest, no one is really relevant for the content of this presentation. So, very simple. These are the goals of non-invasive support. I mean, when you decide to start non-invasive respiratory support in a patient with hypoxemia, what you want is clearly improve gas exchange, prevent endotracheal intubation, and prevent self-inflicted lung injury that we know occurs also in non-intubated patients. From the pathophysiological point of view, the idea is that we want, from one side, to avoid alveolar collapse, mostly hypoxemic patients, and to support inspiratory muscles, so mostly hypercapnic patients. So this is my personal view of how I see non-invasive support, and this is taken also from my friend Giacomo Bellani. If you have purely or mostly hypoxemic patient, what you really need is to increase FiO2 and increase mean airway pressure. So, from my point of view, if you have pure hypoxemia, what you need is PEEP. So I would go for, this is what we do, I will go for CPAP, and for CPAP I think that the helmet is the perfect interface. If you have hypercapnia or muscular fatigue, then you need to ventilate the patient. You need to support the respiratory muscles, so you need non-invasive ventilation. And this can be done both by face mask or by the helmet. And I'll try to see what can add the helmet to the face mask. So this is a helmet, you all know. Again, we can use it for CPAP, free flow CPAP, or for non-invasive ventilation. If you use it for CPAP, to me, this is the perfect interface. Because of, again, you have free flow CPAP, you have very stable pressure levels in the helmet. I think that, at least for us that are Italian, there is no doubt that for CPAP, in non-intubated patients, helmet is the perfect interface. For non-invasive ventilation, you need a mechanical ventilator, and you can connect the helmet to a ventilator with a single port or two separate ports. And of course, helmets designed for non-invasive ventilation are a little bit different from helmets designed for CPAP. They are smaller and ideally more stiff, okay, in order to reduce the compliance of the interface, in order to better transmit the pressure from the ventilator to the airways. So, the helmet has advantages and disadvantages. The advantages are low leaks if you have a good seal around the neck, no face lesions that we frequently see with face masks. In these pandemic times, for sure, it helps to reduce environmental contamination from the patient. As I told you, if you use fresh flow CPAP with high flow, with high bias flow, you have a stable PIP value. You have a known stable FiO2. So if you want to know how much is the FiO2 of your patient at 100% of FiO2, even without PIP, if you put this on a helmet, you are sure that the FiO2 you are delivering is 100%. And of course, it allows more prolonged treatment. It has also disadvantages. There is the risk of rebreathing. Asynchrony, we will discuss a little bit if this is an advantage or not. It's not very suitable for patients with claustrophobia. It is noisy. And you cannot measure tidal volume, at least until now. Now there are methods that... So for CO2 rebreathing, it's quite easy. You need an enough high fresh gas flow through the helmet in order to wash out the CO2 and avoid rebreathing. So if you are doing fresh flow CPAP, it's commonly said that you need a flow above 30 liters per minute, but you can increase it a bit. For noise, okay, you can put earplugs or you can put filters on the inlet. Yeah, you laugh, but it's a problem. Another problem is humidification, because as you know, the air that comes from the wall is dry, and it's very unpleasant to breathe dry air. But you can humidify the helmet, even with active humidification. Clearly, you need to keep, for example, the temperature very low in order to avoid fogging. But with the new humidificators, you can do it. And then there is the issue of patient-ventilator synchronization. So when I started to work in the intensive care, I used to go to the congresses, you know, the SMART Congress in Milan. And the first congress I went, I attended a debate between Massimo Antonelli, who is here, and Antonio Pesenti. And Massimo was saying, we do non-invasive ventilation with the ventilator and the helmet. And Antonio was saying, no, this is not good because the helmet has a large compliance and there is two very bad synchronization between the patient and the ventilator. Indeed, this is true. I mean, the helmet has a certain high compliance, so it needs time to inflate the helmet. It has a large volume. There is resistance of the circuit, and so this turns out in bad synchronization between the patient and the ventilator. So from the moment when the patient starts the inspiration and the moment when the ventilator actually delivers the assist, there is a huge inspiratory trigger delay. And we all think that when you are receiving an assisted mode of ventilation, it's very important that the patient and the ventilator are synchronized. Is it true also during non-invasive ventilation? Well, I don't know. Maybe not. There are studies like this one that show that the more synchronized you are, the highest is the risk of ventilation-induced lung injury, because the more synchronized you are, the higher the tidal volume you develop, the lower the variability of the tidal volume you generate. This is a paper by Dr. Richard in intensive care medicine. There is this other paper by Nutta Polritayama in Annals of Intensive Care, a little bit more recent, but basically same thing. You can see there, if you go from a fully eye-synchronized mode to a non-eye-synchronized mode, you see that the non-synchronized mode is associated with lower transpulmonary pressure and lower tidal volume. So maybe synchronization is not so essential. And maybe the lack of synchronization can be an added value. Because what you do when you do pressure support with the helmet is more like an APRV. It's more like a CPAP from 2 different levels of PEEP. And the patient can breathe freely at 2 different levels of PEEP. Johan Golliger also showed that he compared non-invasive ventilation with the face mask and non-invasive ventilation with the helmet, and he showed that if you apply non-invasive ventilation with the helmet, this with EIT is associated for the same setup and the same pressures with a higher increase in end-expiratory lung volume. So what do we know from the literature? This is the only study that was published before COVID. It's a very famous study by Patel, published in JAMA in 2016. Low number of patients, 83 patients with ARDS, that had been managed for 8 hours with face mask and IV. After 8 hours, they were randomized to continue an IV with CPAP or go on helmet and IV. And the study showed a significant survival advantage for helmet and IV. And one possible explanation is that during helmet and IV, patients were exposed to higher PEEP levels and to more stable PEEP levels. Then COVID came, and we all used any form of non-invasive respiratory support with any device and in any place of the hospital. And this is the ENIVOT study, published again by Massimo Antonelli and Domenico Grieco in JAMA. This study in patients with acute hypoxemic respiratory failure from COVID-19 with, as you can see there, moderate hypoxemia, so PF ratio below 200. The patients were randomized to nasal high flow or to helmet non-invasive ventilation continuously for at least 48 hours. And the treatment was continued until intubation or discharge from the ICU. These patients were in the ICU. The primary outcome was the median number of days free of respiratory support. The primary outcome basically was not different between helmet and nasal high flow, but what was different was the risk of intubation that was significantly lower in patients that received helmet and IV compared to high flow. Then another study was published. This is a large study published by Yasen Arabi in JAMA. More or less the same patients that were randomized to helmet and IV versus usual respiratory support. This was a pragmatic trial, so usual respiratory support could be conventional oxygen, mask and IV, high flow oxygen. So it's a little bit less, how can I say, less strict in the methodology compared to the other one. Again, published in JAMA. And the primary outcome was mortality, and mortality was not different between helmet and IV and the usual respiratory support. So there are several explanations for the differences. I'm not going into this, but if you are interested, there is this very nice what's new point of view editorial, I don't know, again, written by Massimo, Yasen, and Patel, that tries to sort out why these studies are giving different outcomes for helmet and IV. As you may know, we have been working to the new guidelines of ventilatory support for ARDS committed by the European Society of Intensive Care Medicine. I had the honor to chair this process together with Luigi Camporotto and Caroline Calfi. One domain was dedicated to non-invasive ventilation, and one PICO question was, in patient being treated with NIV CPAP for ARDS, does the use of the helmet interface as compared to face mask reduce intubation or mortality? This was in non-COVID patients, and we said that we were unable to make a recommendation since there was only one study, which was the study by Patel, that was indeed positive, but our methodology was very strict and said, okay, it's only one study, only 86 patients, so we cannot really consider this very strong evidence. So in the end, these guidelines will provide no evidence, but probably literature is indeed in support of the use of the helmet for NIV. Last slide. it's also possible to prone the patients with the helmet. It's clearly less comfortable than with the high flow or also with the face mask, but it can be done. We used to do it also before COVID, and again, it's using the helmet does not preclude the possibility to prone the patient, non-invasive, non-intubated patients. So in conclusion, as I told you, I think that the helmet is the perfect interface for fresh flow CPAP, probably has advantages also for NIV, and maybe we have more evidence from COVID-19 than from patients with acute hypoxemic respiratory failure of different etiologies. Thank you very much for your attention.
Any question from the floor? I have one. Sorry, Massimo. No. It's important that you have interaction. You are both the experts, so it's good for us.
Mine is simply an additional information. Giacomo has beautifully shown how the asynchronous may be not so important, and he mentioned various reasons. There is an additional one. When we have an asynchrony, when we have an endotracheal tube, for example, you have both valves that are inspiratory, expiratory valves that are closed. If I try to inspirate, I produce a sort of expenditure of energy without any work of breathing. This is different when you have the helmet, because you can keep whatever would be your inspiratory effort, a small amount of air within the reservoir, which is the helmet, and then your work is not inefficient. It's not an isometric work. It's a real respiratory work. This may be an additional reason. Just it.
Thanks.
Also, I want to question about how you set the respiratory, the mechanical ventilator. How are the settings of mechanical ventilator to avoid this asynchronous, etc.?
Yeah. I didn't. It was in the graphical abstract of the JAMA paper, of the NIVOD paper. I think usually what you do is that you try to make the helmet as stiff as possible. So to use the relatively high levels of PEEP and the fastest possible rise in the pressure. So that's why, for example, NAVA, which is a ventilatory mode that many people say it's very interesting for non-invasive ventilation because it's not affected by leaks. It's not very good to inflate the helmet because during NAVA the pressure rise is more smooth. So you should use like pressure support with very fast ramp in order to, again, inflate the helmet and make it stiff as soon as possible.
Regarding the alarms, any setting, a specific setting, apnea alarm or any? No.
Well, the usual alarms, unless you want. Francesco.
Volume alarm.
Okay. Volume alarm, of course.
Okay. Any other comment, question? Thank you, Giacomo. You did a big effort jumping from one session to the other, so thank you.
All right, then we move to the next speaker. 3:15. We are well on time. Francesco Mojoli, and we switch gears a little bit on quantitative lung ultrasound to predict failure. Thank you very much.
Thank you for the introduction. I had time to rest after my run from the other room. So we can discuss about how to improve our capability to early detect, as early as possible, failure of non-invasive respiratory support. This is a very difficult but important task that we have when we decide to use and to give to our patient a non-invasive respiratory support, because a well-known risk here is that we are delaying intubation in patients that fail the non-invasive support, and this is clearly associated with a poor outcome and an increase of mortality. That is even higher the mortality than if we had intubated directly our patient. And recently, these authors also found the same problem in high-flow nasal cannula oxygen therapy. Oriol Roca studied an high-flow nasal cannula and suggested this new index, the ROX index, that is a combination of non-invasive oxygenation, so SpO2 on FiO2, and respiratory rate. And yeah, he suggested a threshold value, 4.88. If your patient is above this value, there is a higher probability to have a successful non-invasive respiratory support. And this is true at 2, 6, and 12 hours after the beginning of the support. We love lung ultrasound because it's a bedside tool, it's of course non-irradiating, is available in all the emergency department and the ICU, is highly repeatable, and is, at least in our opinion, quite easy. So the learning curve is quite fast. And this is a fast technique because to perform a complete exam, it takes for a non-expert less than 10 minutes. And for an expert, I have to say, even less than 5-6 minutes. And it's reliable. Reliable in what? For sure, as a qualitative tool, suggesting you if your patient has a normal lung, or if there is lung edema, or lung consolidation plus pleural effusion, or pneumothorax, but also as a quantitative tool. So quantitative lung ultrasound can be done very differently in different settings, in pediatrics, neonatal, or outside the ICU. The scoring system that is used in our setting, in the intensive care unit, is this one, is a lung ultrasound score where you analyzed 6 lung regions per hemithorax, so 12 regions in total. And you score each region with a regional score ranging from 0 to 3, where 0 is normal aeration and 3 is complete loss of aeration, so a complete atelectatic or consolidated lung. So the regional score ranges from 0 to 3, and the global score ranges from 0 to 36. And this was validated against the usual gold standard, that is quantitative CT scan. So you see that for each step increase in the regional lung ultrasound score, there is a step increase in the average lung density as assessed by CT scan. So this is the correlation for the regional scoring system, and this is the very good correlation that we found between the global lung ultrasound score and the average lung density at CT scan. And let's say we further refine and improve this scoring system, for instance, suggesting to move from the conventional, traditional longitudinal probe orientation to the transversal scan by rotating by 90 degrees your probe in order to be able to visualize more pleural surface. And with a new definition of score 1 and 2, That means moderate and severe loss of aeration. So the new definition is you give score 1 when the percentage of pleura that is involved by artifact is 50% or less, and you give score 2, so severe loss of aeration, when the percentage of pleura involved is clearly more than 50%. And this way, with the, let's say, last edition of lung ultrasound score, we were able to very strictly correlate with lung density at CT scan and extravascular lung water as assessed by transpulmonary thermodilution. So why not trying to use lung ultrasound at the bedside to early predict successful of non-invasive respiratory support in our patients? We designed this prospective observational multi-center study. Multi-center, it was 3-center study, where we assessed the patient at T0, so before the start of the non-invasive respiratory support with blood gas analysis and lung ultrasound. Then the non-invasive respiratory support could be high flow, CPAP or NIV. So Giacomo don't like this because it's a little bit confusing, but it's real life, so very pragmatic study. Then we perform a second assessment at T1 only after 2 hours. Again, blood gas analysis and lung ultrasound. And the follow-up was at day 3. And the definition of failure was any need of upgrade the respiratory support. So for high flow patient, CPAP, NIV, intubation or ECMO. For CPAP, NIV, intubation or ECMO. And for NIV, of course, only intubation and ECMO. 108 non-invasive respiratory supports were considered for enrollment, and finally 100 were analyzed. On the right, in the table, you see that the etiology of hypoxic respiratory failure, and the indication for non-invasive respiratory support. So mainly risk of post-intubation failure, atelectasis, ARDS, cardiogenic pulmonary edema, and community-acquired pneumonia. These patients were almost all on low or high flow before the enrollment, and the type of support delivered after the enrollment was high flow in 12, CPAP in 69, always because two centers were Italian centers, always with the helmet, and 19 patients were put on NIV, some with a mask and the other with the helmet. This is the failure rate, 21%, not that high. It was a little bit higher, but without statistic significant in high flow. So 21 patients failed, and the main reason for failure was persisting hypoxia as usual. More than 80% of these patients were intubated after the failure of the non-invasive approach. This is T0 assessment. We found a signal in oxygenation, so SpO2 and FiO2 was clearly and significantly different from successful and failure non-invasive respiratory support, and almost significant respiratory rate. So no surprise that the index described by Oriol Roca, the ROX index was significantly different as well. Already at T0, and this is the ROC analysis. It is to be underlined that no signal at all was found looking at the baseline lung aeration assessed by ultrasound. And this is T1. Again, signal coming from oxygenation and respiratory rate. So ROX index was even more different between the two groups, successful and failed non-invasive respiratory support. And what about lung ultrasound? We found a very important difference when we looked at the delta. So the change in lung aeration after 2 hours of non-invasive respiratory support assessed by ultrasound. Here from left to right, you see the ROC curves for PF ratio and ROC index. On the left, in the middle, the global and the anterolateral lung ultrasound score. And on the right, the change in lung aeration assessed by lung ultrasound. So, but for ROX index and for the change in global lung ultrasound, we have an area under the curve of 0.72, 0.73. And when we perform the multivariate analysis, the only 2 parameters that were independently associated with success of the non-invasive respiratory support were the ROX index and the change in global lung ultrasound score. So of course we tried to combine these 2 signals. I didn't mention before, the criterion for the change in delta loss was when there was a value below 0. So any improvement in lung aeration assessed by lung ultrasound was associated with successful non-invasive respiratory support. This was highly sensitive but a little bit less specific, whereas the threshold for the ROX index was a little bit higher than the one described by Oriol Roca, was 9.2. So patient with a ROX index above this value, they frequently experience successful non-invasive respiratory support. This criterion was very specific, a little bit less sensitive. So we try to combine with not ROXUS, let's say ROX ultrasound score, very simple. So if you have a positive signal from the 2 techniques, so an improvement in lung imaging and the ROX index above the threshold, 2 points. If only one is positive, 1 point. If both are negative, 0 points. And these are the curves. Yes, there was combining the 2 techniques. There was an improvement of the area under the curve, moving from 0.72 up to 0.8. And I think it is also quite interesting that this, let's say, combined score was very effective in detecting successful patient. Also when we limited the lung assessment and at the anterolateral regions that are the lung region more easy to be evaluated with your probe. And this was is a way to, let's say, suggest how to apply these findings in clinical practice. If you have positive signal from lung ultrasound score and the ROX index from both, there is a very high probability of success. So, good signal. If both are negative, there is a very high probability of failure. So you have to prepare for the next step. So you have to think about an escalation in the support. If only one is positive and the other is negative, this is a more difficult, let's say a gray zone. But from a pragmatic point of view, I think that this is the patient where we have to increase and apply a strict monitoring, because in the end, 1 out of 4 of these patients are actually failing. So these are my it's 0. Conclusion: early detection of successful patient is an important but difficult task. ROX index and lung ultrasound score variation after 2 hours were independently associated with non-invasive respiratory support success, and the combined approach could further improve early detection of successful patient. Question mark on, let's say, feasibility and cost effectiveness, especially in ICU where the skill on lung ultrasound is not that high. Thank you for your attention.
Thank you very much for this very interesting topic. So the floor is open for discussion. Any questions or comments? Yes?
Thank you very much for the excellent talk. I have one question about whether you compared lung ultrasound score difference between 2 points. Wouldn't the fair comparison wouldn't have been ROX difference between before and after? My question.
Yeah, this is an excellent question and point. Yes, we checked this. There was a difference, very similar, I would say. So if there was an improvement in ROX index, that was a good sign. No improvement or a worsening, bad sign. Anyway, it was not statistically significant. Don't know, probably because of the the small number of our population. But yeah, it's something that we want to check at the next step. Yeah, thank you.
So another question with regards to this ROX ultrasound score. So how much does it vary between operators? So did you also look at variation between colleagues with a lot of experience with performing the ultrasound compared with more less experienced ones?
This is again a very good question. Among expert operators, the variability is very low. We published this in the paper where we validated against CT scan. I'm not aware of studies comparing expert versus non-expert. I think the result could be less good, let's say, but the point is that it's not a basic skill, this. So if you look at the European Society of Intensive Care Medicine definition of the basic skill, the quantitative lung ultrasound is not. So this means that you need an additional training, and after this training, you are an expert. So
do you think it should be basic skill in that set? Do you think it should be basic skill in a couple of years?
Maybe in the next few. This is my will, let's say.
Your mission.
Yeah, mission.
I have also one question. Are you planning any implementation study to validate an algorithm based in the new score?
We'll see. Depends on the when will be published. This is almost finished. Anyway, yeah, it makes sense. I'm not sure if it's okay to use this very simple, so positive signal from one, the other, or both, or it's better to use a combination of two score. So we'll see, but maybe next year.
But maybe you can pilot for that. Okay. Good. So I think we are going to proceed for the next session. Thank you.
Thank you.
So it's my pleasure to invite Adrienne Randolph to the podium. Thank you. She's coming from Boston, US, and she's going to talk about optimal management in children.
Thank you. So I have no relevant disclosures. My objectives are to talk about non-invasive interfaces in children, the rationale for use, recent clinical trials that were just published in JAMA on use of this, and then use in immunocompromised children. So first of all, just understanding the different mask interfaces that are used for children. We don't have a helmet yet for children, for young children, but we do have this full face mask that really is only used in toddlers and below. Then we have the nasal CPAP masks. You can see that they have like to do things to make the child more accepting of it, with tying it to stuffed animals and having this looks like a giraffe. And then with the babies, it goes over the head, and there's it's often best to use a pacifier if they take one to plug the mouth to keep the seal. And then of course we have the nose and mask of all different sizes. And one thing in children is that, you know, a lot of the children have facial, their faces are different shapes and sizes. Often the chin is regressed, and a lot of times the mask doesn't fit. And so you spend a lot of time trying to adjust the mask, because if you don't get the seal, then that's a problem. So this is a RAM cannula. It's supposed to be used for high flow nasal cannula. This is just one company's cannula, but it was published. But off-label use is for non-invasive ventilation. So people use these RAM cannulas that are pretty stiff in babies, especially small infants, for non-invasive ventilation, because babies are usually obligate nasal breathers, and so you can get away with doing that. So the rationale for use for the high flow nasal cannula is really less entrainment of room air, potentially some FRC enhancement and dead space washout. However, and really, although there's some claim that it might be giving some positive pressure, especially in small infants, it's really hard to measure that. And then for continuous positive airway pressure, you know, there's if the whole key is getting the right seal, more precise oxygen delivery, recruitment of alveoli, and consistent pressure. If you have a full face mask, especially, you know, the comparison of the two, one of the things that's really useful in babies, because high flow nasal cannula is used, you know, worldwide in highly resourced countries for RSV bronchiolitis, is that you can feed them if they're not in too much distress. Compared to the CPAP mask is usually we don't feed them, BiPAP never usually feed them. So nutritionally it can be of benefit. So I'm going to go over a couple of trials that were recently published in JAMA by a UK pediatric intensive care unit, a step down trial and a step up trial. And you know, this is some of the recent but best data out there, so I'm going to spend some time going over it. The clinically important question here for step down after extubation, step down trial, was in infants and children clinically assessed to require non-invasive support after extubation. Should you use CPAP first line or high flow? It was a pragmatic, unblinded, 22-center parallel group non-inferiority trial. They did research without prior consent, so they randomized and then got consent. And they stratified it by less than 12 months and over 12 months and by site. They used the sandwich protocol. That was a weaning and extubation trial that they had recently completed that was published in JAMA. And that trial compared usual versus protocolized care in a cluster randomization. But what they did in that trial is they developed explicit protocols in that trial for weaning the ventilator, extubating, and then for this trial, they had standardized protocols, which is super important for use of high-flow nasal cannula. This is in the supplement of the articles, and for CPAP. So how do you go up on it? How do you go down on it? These are published and widely available. You can see also in the bottom part, they titrated the high-flow nasal cannula by weight per kilogram, and they also had criteria for weaning failure and then criteria for stoppage. So this is really, really key, because without these standardized protocols, you could get a positive trial but not understand how to use it in your own center. So study outcomes, because there was no agreed upon core outcome sets for respiratory support trials for children, and treatment failure was often used, reintubation. But reintubation is really uncommon, very uncommon that they fail, and so it's very hard to power something for that. And it doesn't necessarily translate into what's clinically important for the parents. So what they assessed with some surveys, et cetera, what was important to parents is to get off all respiratory support. They want to hold their child, they want to feed their child, they want them free of everything. Even if they're not necessarily out of the ICU or out of the hospital, get all this stuff. And as the child gets better, especially young children, they don't want anything to do with having this stuff on their face, and they get very agitated and very upset, and trying to keep them on the support can be quite a challenge. Sometimes you have to sedate them with dexmedetomidine and other things. So this is was published in JAMA. I told you most about all the other details of this trial, but this is the outcome here. 50.5 hours in the high-flow nasal cannula versus 42.9 hours time to liberation from all breathing support. Okay, so it did not meet criteria for non-inferiority, right? Because the hazard ratio was 0.83, criteria for non-inferiority was supposed to be 0.75 or more, or less, I mean. So basically, it failed to meet criteria with just this difference of 7.6 hours. Now, is that clinically important? Hard to know. The similar results were across all these different subgroups. No difference in length of PICU or hospital stay, which is important. Now, one thing that's really important to note, though, look at this 400. Whoops, I need to go backwards. Can you go back one slide? Thanks. Well, anyways, 422 children were in the under 12 months. That was the majority, 75% of the kids, okay, were under 12 months. The biggest effect was in under 12 months. So that is there wasn't as much in the over 12 months, which ranged all the way up to a teenager. So that's the thing. It's really a trial of kids under 12 months and a lot of bronchiolitis. And RSV was the most common infection. So is this really extrapolable to the other populations of children, older children especially? So the 180-day mortality was, and this was a surprise because we never have a positive mortality trial in children, especially in this population that they're already extubated, was actually higher in the high-flow nasal cannula. So that was a big surprise as well. Why would that be? That doesn't completely make sense. And so when they looked at it, there was maybe a few more cardiac babies in the high flow nasal cannula and this and that. It didn't really, couldn't really be explained. And then no other difference in other adverse events. So, you know, the limitations here was you can't blind this, you know, because you can see what they're doing. The median age was 3 months. 77% were under a year of age. And then, as I said, there was a few more cardiac patients in the high flow nasal cannula. That may have been why there was higher mortality. However, this had potentially high clinical impact because we use high flow nasal cannula all the time now, especially with RSV bronchiolitis. It's even being moved out onto the ward, but it may not provide all the benefits promised in this under 1 year of age subgroup. And, you know, one thing that they noted is that the use of high flow nasal cannula, because people could opt out if they had the clinicians could opt out if they preferred one over the other. A lot of patients, before they could be randomized, were already on it. So, you know, there was a clinician preference and there's a potential for overuse of high flow nasal cannula. So this was the step up trial, right? Okay, so first line therapies, high flow nasal cannula or CPAP, did they fail? Did they get intubated? Again, time from randomization to liberation from all respiratory support is the outcome. And they found completely no difference. So 57.9 hours, 47.9 hours, 52.9 versus 47.9. It did meet the criteria of non-inferiority. So at least from the data that you can see from this study, there was no difference. Again, this was also a younger population of patients. So these data were incorporated into this recently published state-of-the-art guidelines, International Clinical Practice Guidelines for Ventilator Liberation from the step-down trial where it's incorporated into this. And you can't read this, but basically, despite most of those guidelines, there was really almost no evidence supporting any. It was just good clinical practices to screen for, you know, extubation readiness, to do a spontaneous breathing trial. There's no criteria for exactly how you should do the trial, et cetera. But one thing that they did say for those patients that passed the extubation readiness test criteria is, you know, that post-extubation respiratory support for high risk for respiratory failure, and these were the patient populations at higher risk, younger age, chronic lung disease, has been on the ventilator a long time, you know, other genetic syndromes, previously failed extubation, borderline passing the spontaneous breathing trial, that you should potentially extubate to non-invasive respiratory support. And for those that develop respiratory distress as well, escalate to non-invasive respiratory support. But for patients less than a year, if you're going to do non-invasive respiratory support, that was the one recommendation with moderate level of evidence from that one trial to recommending CPAP over high flow nasal cannula. So there isn't a lot of data in other subgroups, but our group, the Polisi stem cell cancer immunotherapy subgroup, we focus on working on a non-invasive respiratory support intervention to try to prevent intubation safely. And so it's a step up study, but we didn't do a trial yet. And one of the reasons we did this is because if you look at those who failed non-invasive ventilation, the mortality was higher in an observational study. This was at my center. In those that you tried non-invasive, they failed, than those you immediately intubated or those who never failed. So trying to figure out why they failed, one thing is that we were pushing it way, way, way too far. And so this is just an example of the top is the respiratory rate, the second one's the FiO2, the third is the oxygen saturation. This is like over 12 hours. You're letting the patient basically be tachypnic in the 60s. This is a teenager. And the FiO2 is at 90%. And finally, they become hypoxic. Happened a lot overnight. and then you'd come in at 6 a.m. or 7 a.m. to start the new day, and then you'd be intubating the patient in a very, very risky way, high risk of arresting. So we developed this protocol that we implemented in 2013 called Nivator. We basically designed it so that you initiate it at a Mozitz level. If they're hypoxic, you do CPAP. If they're hypoxic and hypercarbic, you do BiPAP. We have targets and you monitor the patient continually to achieve targets based on age and respiratory rate. And the goal was to really try to not do these things where you have these disaster failures where you're intubating and arresting, and really intubate early. And I put this blurry because there's no real criteria that you say you have to intubate somebody. That's a clinical judgment, but clearly what I just showed you before is not the right way to do it. So anyways, non-invasive support in infants and children, take-home message, it's commonly used but infrequently studied with any rigor. We really need explicit protocols to understand how people are using it, for whom, and clinically important outcomes vary by population studies. For immunocompromised, it may be different. And excess use is very likely in highly resourced countries, and it could be driving up healthcare costs. Thank you.
Thank you for this excellent presentation. There is any question from the audience? Yes, there are a couple of them.
Hi, this is Xose Pérez from Barcelona. It's a pleasure to have a pediatrician with us because during the COVID, we learned a lot from pediatricians about non-invasive ventilation. And I wanted to ask you if you have the feeling that when you initiate non-invasive support, ventilatory support, maintaining as far as possible in terms of not disconnecting, it's better. I mean, I don't know if you understand what I mean. Just maintaining,
right.
not disconnecting continuously, depressuring.
Yes, so that is the goal, is to not disconnect frequently, to maintain especially for CPAP, and the BiPAP is to do it continuously. Sometimes we have to sedate with dexmedetomidine to get the patient to tolerate that. But yes, and then to wean, and then sprint when they're improving, sprinting them off.
Laurent?
Laurent Brochard from Toronto. Thanks very much, Adrienne. A couple of questions. In the adult studies, a big difficulty for interpretation is the high rate of crossover. So was it the case in the step up, step down? And second question, I like your mention of overuse. How could we assess that or study that more?
So as far as the crossover, the one thing about those trials is there was a lot of clinician preference for what they thought, and so there was a huge amount, not huge, but a fairly high amount of patients who they had opted out of the trial. And so that kind of took care of some of the crossover, because then there was some crossover when they failed high flow to go to non-invasive before re-intubating, because none of us want to re-intubate and resedate and everything. And then your second question, were you talking about the Nivator protocol, or what protocol were you talking about?
The other use in general.
Oh, other use in general of non-invasive ventilation. I mean, it's fairly, we really now intubate a smaller fraction of patients and do try non-invasive ventilation a lot. I think sometimes it's unsafe. Some of these neurologic patients shouldn't be trialed on it because they aspirate. Sometimes we still push patients too far because people are trying to get away without intubating and don't realize, look, the lung disease is so progressive here. What are you doing? Look how everything's rapidly escalating. So we don't have any criteria, and it's being used more and more and more. We don't know if it's causing harm.
Thank you.
Thank you.
So I have the same impression than Xose, that we were very lucky during the COVID outbreak that we have pediatricians working with us. But we were also very lucky this winter because you have the bronchiolitis outbreak, and we were not needed in the pediatric ICUs, which is we will be struggling for sure. My question is regarding the trial. As you mentioned, there is some disbalance according to the diagnosis, and maybe this can explain the difference in mortality. But I didn't see the subgroup analysis on bronchiolitis. There is any difference in bronchiolitis, and it may be interesting to have a specific trial in bronchiolitis.
I mean, the number of patients in that study who were RSV positive, which is, you know, a lot of those had bronchiolitis and who were under 1 year of age, that really was, in a way, kind of a bronchiolitis trial. However, with the expanded use out onto the ward of high flow to less sick patients, you know, they wouldn't have been in that trial because this trial was, well, this was stepped down, extubated. Most of the bronchiolitis patients aren't intubated. So I think that a lot of data can be seen there for bronchiolitis. Stepping down from the intubation is, you know, it looked like CPAP was better than the high flow nasal cannula. But either one, you know, overall mortality was very low, and you're talking about 7 hours. So both of them could be considered safe.
Thank you. Okay, thank you.
We're running nicely on time, so now we will move to the next speaker, Laurent Brochard, and we will learn from the real expert how I use high-flow oxygen therapy.
Oh, thank you very much. So I think the topic, I would say, needs no introduction. Everybody is familiar, so these are my conflict of interest. We received equipment from Fisher-Paykel, who is doing this equipment. So again, it has become familiar to everyone that with the high flow technique, you can control the flow and the FiO2. You warm and humidify the gas. You deliver with a non-condensing tubing, so you have no water directly coming into the lungs. And you use nasal cannula. And we think that there are more or less 4 potential advantages. You match patients' inspiratory flow, and the FiO2 is stable, which, by the way, makes sometimes interpretation of result in studies a bit complicated because you see a better PaO2, FiO2, but it may be simply better because you have a higher global FiO2. There's this low CPAP effect, lung recruitment. I will discuss that. And we all know, we have measured that when the patient has the mouth open, there is no positive pressure. So it's a bit strange that it seems to be a CPAP effect without positive pressure. There is a very good humidification, which is the only reason why patients can tolerate high flow. It's absolutely intolerable to tolerate cold flow, high cold flow. And if by mistake you forget to switch on the heater humidifier, the patients will worsen very quickly. So that's good to know. And the last thing is this washout of dead space, which is really a very, very nice concept. You expire CO2, and this is what you re-inspire at the next breath. And if you have fresh gas during the whole inspiration, at least what you inspired at the level of the vocal cords is fresh gas. So you decrease this part of the dead space, and this is a very unique way to decrease the work of breathing. All other techniques either improve mechanics or add additional support. This one decrease your needs or decrease the needs of the patients, and this is a really interesting one. And we have data. This is one study from Tommaso Mauri on the right. You have the pressure time product, which is let's say the energy consumption of the respiratory muscle over 1 minute. And I think this point over 1 minute is important because you will see that the respiratory rate plays a very important role in the effect on the work of breathing. So just to mention some of the data we gathered, there is another mechanism which I think is important, with high flow, which has not been really very well described, which is the possibility to increase airway resistance. Oh, this looks very counterintuitive because you say this is bad if you increase resistance. So we did a quite complex study, and just this illustrates the fact that we compared the different rate of high flow, 20, 40, 60. We compared mouth open, mouth closed, and we compared to CPAP to see whether there was any difference with CPAP. And it's hard to see, but if you look at the flow, the higher the flow, the lower is the volume for the same effort. This was a simulated study, and then we did in healthy volunteers. And we calculated this inspiratory and expiratory resistance. And especially for expiratory resistance, it's clearly much higher than CPAP, for instance. So you expire against resistance. And I think this is, for instance, if you look at the classical physiology studies, the response to increased expiratory resistance is lengthening of the expiratory time. So I think this is the main explanation why the respiratory rate decreases. And you may have seen, if you do it on yourself, it may be spectacular. You may keep a very long expiratory time. And why is this important? Because if you decrease respiratory rate, and if you don't increase your tidal volume, you decrease minute ventilation, and this may be the main reason why you decrease your work of breathing. So two effects combine. One is the washout of the dead space. One is this increased expiratory resistance. And there are very nice experimental studies who show that if you increase the expiratory resistance, you keep the lung open more for a longer time, and you decrease lung collapse. So it may not be the PEEP effect that we describe, it may be this effect of the expiratory resistance, which, however, is also lower if you open your mouth. So again, that's important because in the future, if we know that we have these different mechanisms, the pressure, the flow washout, and the expiratory resistance, with different types of cannulas, we may have different respective effects, right? There is now an asymmetrical cannula which is being tested, and you have also in the literature interesting reports where people used a single cannula, just one nose. So I think we'll know better in the near future. Just to remind that there have been a lot of studies, and then this was very rigorous guidelines led by Bram Rosberg and Karen Burns, and I will mostly focus on the hypoxemic respiratory failure. This is how I think the number one indication. It's really very, very highly influenced by this study, which has not been reproduced so much. We have some positive studies, but many are not that positive, and which was a bit a surprise, I would say, because if you remember correctly, this was comparing three techniques: NIV, high flow, and just nasal oxygen in patients with mostly community-acquired pneumonia. And the question was, does it decrease intubation, which may turn into better outcome? And the answer was no, because the primary outcome was in every patient with PF below 300, there was no difference. However, there was a difference in the subgroup of patients who were most hypoxemic, PF below 200. I'm saying that because maybe if we address the question raised in the preceding talk of overuse, maybe sometimes it's overuse for patients who do not need it. But what was really fascinating in this study was that for the whole group, this is now taking into account PF ratio below 300, there was a difference in mortality, in survival at day 90. And you see there was no effect of NIV by itself. So, which really is interesting and important, if true, or if reproduced in the same conditions. And the it raised the question, why would patients survive better, even without less intubation? And that's one possibility, which is that because you decrease minute ventilation, you decrease the risk of patient self-inflicted lung injury, for instance. So we use it a lot. This is the data of the systematic review and meta-analysis, and you see that in general there is clearly, it's impossible to read, but there is significantly less intubation. It's more difficult to show a difference in survival, and it's a technique which has been used a lot during the COVID-19, and we used a lot, as I guess many people. There has been a lot of data suggesting it could avoid intubation. This was at the beginning of the pandemic. It's an emulated trial, so it's not a real randomized trial, but you take the observational data and you try to adjust for differences, and there was significantly less intubation in the group treated with, or I'm showing the oxygen mask. This is more intubation and less intubation in the high flow. And there was at least one randomized control trial which was performed in Colombia, very well done, and they found that there was significantly less intubation. Sorry for that. Significantly less intubation and a better recovery. No study showed the difference in mortality, right? But however, if your patient can be discharged from the ICU without being intubated, I think both the patients and the team would be happy. Just one point to say, because it has been so much and so frequently, people now are saying, well, there was a lot of patients we would normally call ARDS who were in fact treated with high flow, which may be true, and there is discussion about whether we should expand the definition of ARDS, at least for the trials. And the data here from Marco Ranieri suggests that most patients who have a PF below 300 under high flow after intubation, for those who are intubated, still have a PF ratio below intubation, below 300. So saying, well, these are the same patients, but before intubation, the actual definition makes it difficult. I don't know whether it's really important for most clinicians, but it may be important for future trials. Just another big indication, and I'm not going to go through all indication, is post-extubation. I think it has showed that it could help. Some results are a bit puzzling because we see that it seems to be very efficient to prevent reintubation, even in low-risk patients, which is still a little bit hard to introduce into practice. It is not shown in all studies, and for instance, this study by Arno Thiel, multicentric, showed that high flow plus non-invasive ventilation was more efficient than high flow. And in a post-hoc analysis, it showed that this was true in the overweight or obese patients. Overweight meaning just BMI 30 or above, so that's a lot of patients in the ICU. And the data suggests that non-invasive ventilation combined to high flow is better. And so that's how we use it, for instance, in our ICU. Just to mention that not all studies are positive. This is a very nice study done by Rino Maggiore, who found no effect on reintubation. There was just less crossover to non-invasive ventilation, if you want, in the group treated with high flow. So the studies are not so strong in intubation, and it's a little bit difficult to define what are the limits. Okay, just a final word to say it's tempting to use in chronic CO2 retainer coming to the hospital because of the CO2 washout. We have much less data. In our center, we have a lot of adult patients with cystic fibrosis, so we did this study which showed that in stabilized patients, it could be used as an alternative to NIV. And that's good for this patient because it's really hard sometimes to tolerate the mask for a very prolonged period. In COPD, very few data. This is a nice study from one of our previous fellows from Toronto, Nutapol Ritayamai, who did that in Bangkok. He progressively increased the flow rate, and he found that he could come to a work of breathing equivalent to BiPAP. Interestingly, in some of the patients, when increasing the flow above 30, he found that the work of breathing increased, suggesting maybe this mechanism of high resistance is not so well tolerated with higher flow. And I think we need to learn a bit more. Do we need a different adjustment in these patients? And I think the NIV for patients who are with COPD exacerbation is still the best first-line treatment. But it could be maybe you could alternate with high flow. So these are systems which provide really optimal humidification, and that's a great advantage in terms of comfort. It works like an internal assistance, and I think it can be the first-line therapy in hypoxemic respiratory failure, but its use in association with other techniques may be interesting. Thank you very much.
Thank you very much. Yeah, there's a question at the back of the hall. I think there's a microphone coming.
Thanks so much, Dr. Brochard. I guess I have two questions that sort of factor in from the last slide that you gave about the study that your fellow in Bangkok had done. So one of the questions I often face is how to figure out what the settings for high flow that we should opt for might be. And Dr. Randolph had mentioned how they have a nice protocol and there are a couple of studies. And so particularly with the questions related to preventative strategies on extubation to prevent reintubation, where I'm not really targeting something particularly physiologic about the patient. How do you think about settings there, recognizing our lack of data? And then secondarily, given your fellow's study, how do you assess work of breathing at the bedside so you don't run into that problem?
Yeah, so maybe the second one, this is a big issue because I think I'd love to be able to measure work of breathing in many of my patients. I think this is the best indication for intubation, and this is something we cannot measure. So the best we can do is estimate the activity, the tonic activity, the phasic activity of the accessory muscles. The respiratory rate, unfortunately, is not a very good indicator. Just to keep on this issue, I found interesting that there are several studies where, let's say, a surrogate of the effort is to look at the tidal volume, which you can measure when you put a mask and a ventilator. And that's interesting because, for instance, it predicts quite well NIV failure when it's really high tidal volume. And some people say, instead of the ROX index, which use the frequency and the SpO2, FiO2, we published a short research letter in the blue. They do 2 minutes of face mask to measure their tidal volume, and well, this is a bit experimental, but that's interesting. And lastly, another techniques people are trying is to put a small catheter in the nose, so you occlude the nose, and the swings may be an estimate of the esophageal pressure. Just to say, this is a big issue which we don't have a good solution. So that titration is an issue for the high flow. I think that was your first question, and I would say certainly ask the patient, and when going up on the flow, and sometimes the temperature is an issue also. So ask the patient about their comfort, and the respiratory rate in this case is specifically interesting because if you have so for two reasons, the bench studies, let's say, show that the higher the respiratory rate, the less efficient is the technique. You have less time to flush the CO2. And then when it works well with this expiratory resistance, you see this lengthening of expiratory time and decrease of respiratory rate. So again, it's not very detailed physiology, but I would say ask patients comfort and look at the respiratory rate.
Okay, once again, there's one last quick question.
Okay, I had a personal friend who I visited, he was treated with high flow. He said, I don't like it. I say, the data show it, you should like it. And then we look at the humidifier, it was off. This is terrible. Okay. This is terrible. Cold air, it's increase your, it will create nasal congestion very quickly and also may increase the bronchial resistance. So that's the biggest mistake.
Laurent, any comment on the different available devices, standalone or in a ventilator or are equivalent?
No, I don't think we have very good data. My feeling is that it's very similar. Mm-hmm. However, again, we see more different cannulas, and I think it has not been studied well. They have different effect on the pressure they generate, the CO2 clearance, and there could be difference that we have not studied. But so I think if you use it on a ventilator, it should be very comparable.
Okay. Thank you.
Last question.
Okay. Yeah. One more question.
What would be your recommendation on starting parameters? Because I've heard 60 liters per minute gives you the best P, but at the same time it gives the resistance is the most at 60 liters per minute.
Maybe that's overlap with the preceding question, right? That would be, if you want maximum efficacy, you want to reach the highest flow, but some patients may not tolerate, and it depends kind of patients. We did this study in patients with cystic fibrosis. Many of them did not like the highest temperature, so we reduced the temperature, and we went up on the flow. Most of them were happy with relatively high flow, 50 or higher, but some again were a bit uncomfortable. So it's really about asking the patient and titrating up.
Okay, we are closing here. Thank you.
Thank you,
Laurent. So I think it's going to be the last session, or the last topic for this session, which is bioimpedance could help to predict failure by Xose Pérez from Barcelona.
Hi. Well, it's a pleasure to be here. Ricard knows that this is not my field of expertise, and I'm a little bit embarrassed to talk after Laurent Brochard. I thought Gattirone was going to be after, so it was even worse. Antonelli sitting here, so it's. But I really wanted to give this talk because I feel like a part of the crowd. That I had a lot of questions while we were in the middle of the COVID. And I have no conflict of interest related to this field, to this talk. And this is my hospital, who was severely hit during the first wave, especially, like Ricard's hospital. It's a public hospital, as you can see, working class district. Not Gaudí district, nice Barcelona. This is a working class area, and we are a big hospital, and we receive a lot of patients. I work as an ICU physician, and again, I'm not an expert. I'm a little bit expert on fishing. Don't worry, the fish was returned to the water. My son was really worried, and I love wine too. So my daughter is trying to arrange some things. So these are probably the only things that I really know something about. But not, again, respiratory. Although I had this feeling after the first wave in my hospital, it was quite hard to work there. We got angry even with colleagues because we all had different opinions. This is my friend, David Dominguez. He loves Lamborghinis, as you can see. He's one of the smartest guys I know. He's in internal medicine in Vallebron. He afterwards left soccer, so he entered Football Club Barcelona as a sport medicine. He did the specialty too. And now he works, he realized that Football Club Barcelona was not really sport. So he went to the Olympic sport women and sport men, and he works with them in the physiology department of the sports center in Sant Cugat, which is a high competitive center. He gave me the idea because we were discussing what to do with these patients we had connected all the time to the non-invasive ventilation during the COVID. Those patients at the beginning were on the ward because we had no place on the ICU. We only received patients to intubate. High-flow nasal cannula was on the ward, of course. We didn't receive those patients. And sometimes we had some non-invasive ventilation patients. Of course, after the first wave, we started to receive these patients. And these patients were a lot of time on non-invasive ventilation. And during that time, we were not sure if we were doing right or wrong, because we didn't know what to do with nutrition, and we didn't know really if those patients were getting better or were just sustaining their condition and finally collapsing. So we need some tools to predict if the non-invasive ventilation was going to be successful or not. And talking with David, we talked about estimation of calorimetry with a bioimpedance method they had with the sport men and sport women. They were able to connect. And he talked me about I had no idea at that time of what bioimpedance was. I had heard that nephrologists use it, etc., to measure volume, corporal volume, fluid. But at that time, I had no idea. So let me introduce you just some basic principles about impedance. You know that we basically measure muscle mass on water in a very basic standard, and we are measuring reactance of our cells and the resistance. That depends on the amount of water we have. And then we have a very important parameter, which is the phase angle, which measures the delay between the voltage and the current. So when we do impedanceometry, we have these new machines that they can measure like 5 cylinders. It's not like before that it was only a whole cylinder, but we have now special machines that can measure like 5, the 2 arms, the 2 legs, and even the truncal area. So we are capable of measuring the patient has a cachectic state or overhydrated edema, depending on the values we obtain. The machine we use was, we talked with the industry, and they lent us the machine. With this machine, we were supposed to measure fluid status and muscle mass and determine if this could change the outcome of our non-invasive ventilation, because we know that sarcopenic patients are more time on mechanical ventilation, more length of ICU stay, of course, and of course, what about fluid overload? We all know the deleterious effect it has on critically ill patients. So let's talk about some scores we had at that time, because again, we were supposed, in terms of procedures, not to use non-invasive ventilation in patients who were with a PO2, FiO2 below 150. That was from observational studies. We were supposed not to use steroids on patients who had COVID pneumonia, but that was based on H1N1 observational studies. So a lot of observational studies with a big data that had told us not to use things. But we had to use, because nature is sometimes tricky, and we had so much amount of patients that we could not intubate all of them. So we had non-invasive ventilation, and we learned with this nice lesson from nature that it could work in some patients. We had the Hacker score, which is based on observational study, China. We thought that this could be correct, and we use it because it's basically in physical respiration and measure respiratory rate, level of consciousness, have a gasometry. So it's quite simple, and it really works. You have to be beside the patient and measure things. What about the nutrition? We have here Mr. Massimo Antonelli, who I was listening the other day. He was saying that they perform, which is, I think, it's incredible, nasogastric nutrition in this. I'm not an expert on nutrition too, as I told you before, but for us, it was a big dilemma, what to do with these patients. When those patients were on the ward, remember, in the first wave, some pneumologists who were in charge of them, with non-invasive ventilation, hypoxemic respiratory failure, they put parenteral nutrition on those patients because they thought that they had to put nutrition. So I had big discussions with my guidelines, no specific recommendations. This is quite shocking because we have a big amount of patients during days on non-invasive ventilation, but we have no recommendations at all what to do with these patients. French are very smart, and they can even try to do these incredible things with snorkeling mask and putting the nasogastric tube across. But my friend Juan Carlos López Delgado, which was the nutritional expert of the unit, at that time we had terrible discussions what to do with these patients because we didn't agree with each other. So he was saying that maybe parenteral, because enteral they may be more bronchoaspiration. And at that time, some of the patients were entering parenteral nutrition, some of them were receiving some supplemental hyperprotein apport or supplemental nutrition, and that was all. So we tried to measure things. We applied, we performed bioimpedance in non-invasive ventilations, patients requiring non-invasive ventilation. These patients were all of them on non-invasive ventilation support. We finally analyzed only the patients with COVID disease because we wanted to have as homogeneous as possible population. And as you can see, these are real results. This is observational. It's nothing. It's not randomized, so it's a reality. And I'm not going to hide anything. We had a global mortality of 32.4. If you ask me what was the mortality of the non-intubated group, it was 5%. And if you ask me what was the mortality of the intubated patient, it was 50%. Okay. So as you can see, and you can throw stones and say and tell me most of the patients were intubated lately, more than 5 days. So maybe we were too late, but it's observational again. There was no difference in mortality. There was difference in those who survive in terms of ICU stay. That's true. That's true. So if you intubate late, at least in our population, and the patient survives, that patient is going to be more days on the ICU. So as you can see, we had a quite population with high body mass index, as I'm sure that everybody suffered. And these are the data comparing the ones that were non-intubated against the ones that were intubated. Sorry, because here the PO2, FiO2 data are missing, but there was practically the same, 104, 110, 110 obviously in the non-intubated group. And well, it's interesting to see that there was no real effect on the differences in the tidal volume. Probably those patients who arrived a little bit late to the ICU were those ones who were receiving previously non-invasive ventilation, were intubated with more frequently. Hacker score seemed to work, especially the first Hacker score measure, not the 1 hour that was recommended. And impedanceometry was performed during the first 24 hours. So all patients, all these 74 patients received impedanceometry was measured in them. And as you can see, all the parameters we have the most significant in terms of differences between the non-intubated group and intubated was the phase angle. When we perform multiple regression analysis, which is with 74 patients, I agree that it's not statistically very correct, but that's, we all do it. Phase angle, it's even stronger than Hacker score, which was, for us, it was quite shocking. And if you put a Kaplan-Meier in terms of non-invasive ventilation success, we see that they're practically Hacker and phase angle with a cutoff point of 4.2. All the population under 4.2 had obviously more risk of non-invasive ventilation failure, they were intubated with more frequency. Interestingly, our population, we observed that the group with obesity was clearly benefited from the non-invasive ventilation. That has nothing to do with impedance symmetry, but it's nice to see that this obesity population seems to benefit more from a non-invasive ventilation approach. So our proposal for the study, this is observation of what we've seen till now, would be perform a trial using, of course, impedance symmetry to measure to guide a nutritional intervention in this kind of patients, which I think we should try to do. We have a lot of patients with non-invasive ventilation support, and probably an intervention in terms of nutritional could change the outcome of these patients. So we have that feeling. What can we do? A randomized controlled trial, of course, and nutritional intervention, which we still have to settle. I don't know if it's going to be parenteral nutrition on day 3, or probably not that one, but probably some supplementation with micronutrients and protein and calorie delivery. We have to see how. This would be the NIVER study. And basically, the other endpoint would be to do a composite score with phase angle and Hacker score, which is under construction yet. So just to finish, my conclusions would be that impedance symmetry can be a safe tool to evaluate ICU patients from the metabolic perspective. Body composition measured by impedance symmetry may predict outcomes in patients on non-invasive ventilation support, especially phase angle. New studies are needed to elucidate the impact of nutrition in this kind of population, which is, I think it's more and more frequent. A NIVER study could be an excellent opportunity to increase the evidence. If someone wants to collaborate with us, we will be very pleased. But before I leave, let me ask you, how did you apply your non-invasive ventilation support? Because we were talking before with the pediatrician, we learned from the COVID and from those big amount of patients that were under non-invasive ventilation. We've been always a non-invasive ventilation center, but we learned that probably these first 24, 36 hours where we maintained the pressure, most of the patients were BiPAP. We were using pressure support besides EPAP. But we observed that those ones who were maintained during 24, 36 hours, just making very short depressurizations to give something by the mouth and connecting immediately, those ones are the ones that do better. To maintain the sensation or the feeling is that maintaining the EPAP or the PEEP as much time as possible is beneficial, and it makes sense. And this is our algorithm that we created with the help of the pediatrician department of Sant Joan de Déu, and we were very happy to. This is the NIVER team. A lot of people here. Carlos de Sant Cugat, people from our ICU, Juan Carlos, and people even from the machine that lend us the machine, and it's been a pleasure. Let me invite you to a symposium we have, which is in renal replacement therapy. It's another different story, but you can come to Barcelona, to our hospital in October. This is my email. Whatever you want to ask or share or collaborate with us, we will be very pleased. And last, remember to Jordi Mancebo, who was one of the opponents of this, or the speakers of this symposium, which we performed 2 years ago, and we didn't talk about renal replacement therapy. We only spoke about mechanical ventilation at that time, and I'm sure that we all miss Jordi, and he was a very good friend, and thank you very much.
Any question for Dr. Perez? I want to ask you, because in fact, you are measuring frailty, right, with the bioimpedance and this score, and frailty has been a criteria for deciding ICU admission. Do you think that can bias a little bit your results, or it deserves to study also the patients that we decide not to admit in that during the COVID times in the ICU?
The 74 patients that are included here, they're not really very fragile patients. I mean, we have most of them are quite young. They had an initial physical. I mean, we didn't put non-invasive ventilation support on 76-year-old with a cachectic that we knew that he was going to fail. We didn't do that. We used non-invasive ventilation in a lot of patients, in a high percentage of patients, but that patient had to be in a good physical condition. But sometimes, I agree, the machine tells you what you see with your eyes. That patient is cachectic, has sarcopenia. But sometimes it's one more tool, and it's non-invasive. It's very easy to use. And probably we only did one measurement, first 24 hours. But the idea would be to monitor these patients and do another measurement probably at day 3 or even every 24 hours. It's very, very simple to do. In 5 minutes you have the result. And I think it would be very interesting because as you do Hacker score every day, or even less, you could do impedantiometry. And I think it's quite useful. I find it quite useful.
And any correlation with other biomarker of the nutrition status, albuminemia?
Albumin, of course, albumin.
Okay. Okay, thank you very much. And congratulations with this collaboration with the Sport Medicine. So we are going to close the session. Thank you for being here until the end. Thank you for the participation. I think it has been amazing. And I think we have learned a lot about non-invasive mechanical ventilation because sure, we are not experts, but we have learned a lot. Thank you very much.